After 2 months, if delay is substantial, then they will pay attention for therapy. So sometimes you have to take a judicious call based on the parents' assumption. Like one baby we were seeing with Amjad. Okay, that baby had so much of spastic nature. Today when I am seeing this baby, I think the team was, whose team? That madam is not there? Your team, right? Mother's was quite spastic when we saw the baby. And I was also wondering, can we correct this baby? But today when I am seeing along with you, I am surprised that, oh, baby is doing like this.
So she was spastic.
So she said, I want you to take photo with my baby. I think first time a Saudi mother is ready to take photo with me. Normally I am so much concerned. I am too much afraid to taking photos of any babies. Okay, but if she is telling, that means absolutely baby is showing correction. Believe me, we were not able to turn the baby at all. We were not able to move the lower limb. It was so stiff.
Still, I have the question. Why you
I
decided
will take your question when I present yours.
Yeah,
That is how you understand.
next to Grobia. This is
Because the team whose case is this, they will understand their case better. So that is how I can present another case. Is that clear as of now?
Excellent.
Yeah. You want to speak on this?
All for the problem only, or for all? All. صح كده؟
So you have a score of 80. So when you have a score of 80, baby is transient. So when the baby is transient, just because the 15 months old baby not working. So where you want to intervene? You have to intervene at all fours. You have possibly child will have abdominal weakness. So that is the reason child is not crawling. Possibly child will have lower trunk initiation weakness in the all four position, so that your baby is doing this, okay, but baby doesn't know how to bring this.
Yes.
If the baby doesn't know how to bring this, baby will not stand up. So you have to intervene there. So now clinically you justify really your baby has abdominal weakness. If you confirm baby has abdominal weakness, you work on the abdominals on the ball. And you directly, because 15 months old baby, so after working on abdominal if you work, now I am talking therapy, okay? So we call it flexion control. So you work on flexion control. Flexion control is, you take the baby, okay? You take the baby and tip the baby back. Moment you tip the baby back, because your baby has got all the righting reaction except backward. So what child will use? Child will try to come front. Child will do come front, child will do the concentric abdominals. Okay? And from there, you make the child sit on the bolster or the ball, tip the ball front. The child will have more extensor control in the spine, more abdominal recruitment, and the child will land feet on the floor. Slowly, ball will be on the back side, and then child will be having this position. As the child will recruit the abdomen, anterior pelvic tilt will correct, then child will have straight position. Child will have straight position, slowly straight position you practice, then you withdraw the ball from the back side, child will start standing. You go ahead with the walking. That's it.
So for the reassessment, because they're transient,
3 months, 18.
3 months, always it's like that, or
Not
it's
problem.
different from child?
Because just a small problem we are seeing. So this particular correction possibly we assume that will take 3 months. So that is better to call 3 months to do the intervention. So and scale has applicability till 18 months. Okay. So 18 months you can see the effect of it, your intervention, because just hardly few items where child is scoring 1.
This is my group.
Yeah.
My member has a question
Yeah.
regarding the colon.
This is your team?
Yeah.
Yes.
Okay. Go ahead.
They were very excellent.
Yeah.
But someone has one question.
Yeah. 20. Spasticity.
Yes.
Correct?
Yes.
I addressed this. I already addressed. Okay. First factor question is, I go back. Okay. Okay. So the question is, if the child has 20
معك
score,
السوق بتاع كابل شحن.
that is maximum score. Okay? Absolutely, child doesn't have spasticity. Had your baby had spasticity, score would have been less.
Flow.
That's the issue of the spasticity.
Your score will be less. Whichever factor child will have low score, that factor child has problem. So if your baby is scoring high, child doesn't have any spasticity. Because child doesn't have spasticity, that is the reason you have a flat throat. That is the reason your child is able to sit well. That is the reason your child has standing with the inferior pelvic tilt. That is the reason your child has got lateral writing. Okay? So now, can you correctly interpret why your baby is dropping? So when you look at your scale, your baby is dropping because a functional transition in all fours was absent. What does it mean? Whether baby was allowed to have functional transition late or baby learned functional transition late? Answer could be baby learned functional transition late. Which transition? That is rotative one. Because rotative transition got late, so all fours didn't come. Crawling position didn't come. However, culturally mother was able to make the baby sit, baby is able to sit. So, as such, baby can sit by self, all fours not there, baby is not able to sit by self. So higher score in any factor, child doesn't have problem in that score. So now, from the item you pick whether you have such factor present or not, spasticity, or problem in the head and trunk, or vestibular, or lower limb, or French angle. So when you look at this, you pick this one, that is this. It falls under head and trunk posture. So what you have to do, child has a problem in the trunk, grossly. Correct the trunk, problem solved.
I have a question.
Please.
If my child has nothing yet clear, so I want to start the treatment, shall I interfere him to transitional treatment first or positional approach, or both together, or a little bit confusing?
Okay, right now what I am doing is I am teaching you therapy, but I am teaching you how to interpret the score items, okay, on infant. Second thing, as I come to that understanding for you, then you have automatic question, what is my solution? Okay, that also I am giving you answer justifying through the scale finding. Clear? I just address this. Okay. Now, unless you bring the baby on this, I will not be able to answer you. Okay. Morning I said I will present one case to you. Let's see if my computer accepts this. Or this case. This is a preterm baby, okay? 30 weeks preterm from India, okay? And the baby had AST and PDA. PDA is closed, AST is still there, okay? Now, can you pick from here? Can you understand? No, I know only side project you cannot pick. This case was sent to me yesterday. Lucky you are that you got a question like this. Or rather, I am lucky. These were the reasons I wanted quickly all of you to move here. Lucky, sometimes it takes time. Okay. Sometimes half an hour I try computer to accept my phone, doesn't accept.
فنور بسم الله ما شاء الله.
Done. Now we play. Can you identify the problem?
It does.
Why is it here?
See, can you fix the problem?
That's, yeah.
Now you can pick.
Spastic, she's really spastic.
Symmetry.
If she is spastic, why she has abducted leg? She is 1 year 10 months old child.
She doesn't have stability.
No problem.
Definitely.
She is 1 year 10 months old baby, preterm 30 weeks. Okay. With AST not yet closed, PDA closed. Okay. Problem is on the left side. Okay. Left side there is a quietness. Left leg is outgoing. Left outgoing. Okay? Look at the left. Left outgoing.
Clear.
Observe, not right. See, left out. Okay? Left up with the navicular drop and equinus and valum. So you call it equinovalgum. Calcaneum is in valgum. Okay, how parents got the complaint? Parents got the baby a sound making shoe. So on the right foot when the child lands, it makes the sound. Left foot child lands, doesn't make the sound. That is how the parent got concerned. Before that, parents were not knowing, pediatrician were not knowing. Now this baby, if you do foot grasp, dorsiflexion, you will see asymmetry, gross asymmetry. Can this be a case of monoplegia? Left side monoplegia, probably. Clinically, I haven't seen the baby. Okay, when I go back that time, I will see. Clinically, I haven't seen the baby, but it looks like this. Can you see left side high guard posture? See, left side always high guard. Right upper limb comes down. Left upper limb doesn't come down. Observe this. Okay? So the truncal, so why the baby does like a hemi? If you have a left hemi, they continue to walk like this. Okay? This is called postural strategy. Patient uses the arm as a postural strategy, not to lose the balance. So the child doesn't bring the left hand down. Observe throughout the gait pattern. Okay? So that means child walks with the high guard, like this. Okay? But it is not scissoring. That means probably child would have some kind of a hypertonicity in the plantar flexor. Why plantar valgum? Why equina valgum? Because subtalar is collapsing. Why subtalar is collapsing? Because possibly child got laxity over the ankle. Plus child has a 4-foot landing. So when the 4-foot landing, somewhere the break should happen. You have a 3 rocker in the foot. I hope you know. Okay? So somewhere break should happen. So at the subtalar level break is happening. Subtalar level break is happening. That is how the navicular bone will give away. So when you look at this, navicular bone is out more here. Navicular bone on the left is more out. That is how the calcaneum is going for valgum. So message is that unless you bring the case, okay, or unless you evaluate the case on your scale, it will be so difficult for me to interpret. Hypothetically, we can have any situation, but if you want to bring your case, you have to ideally project the case, and then maybe 50% I may be accurate, 50% I may be wrong. That is possible. Okay, so if you have any concern, you please bring your case. That will be the best way to understand. Okay, yes, madam, you had a question. You forgot. Yes, and anybody else? Any other thing?
If we can get YouTube to learn more about this or whatever.
I didn't get madam.
How we can keep ourselves up with this audio? Do you have website or whatever so we can upgrade ourselves?
Okay. I am not on Facebook. With so difficulty, I'm just telling you how I am. Okay. I don't know so much of electronic media. Okay. Maybe the way I work, I'm not so much projecting myself out. But when I need you, I do, because by nature I am an academic person. Clinical practice, yes, I am a clinician. So I bring the academics and clinics together. Okay?
That's why we enjoy it.
And that is the reason I relate your academic research and the clinical information. Okay? If I do on the media, one of it I will miss. Okay? That direct answer is that I never try to do that. And I don't know if I can ever do that. I never thought. But when I get lost, I just get into it. Then I do not feel hunger, I do not feel sleep. But the moment you all leave me, believe me, I go back to my sleep. It's like this.
So tomorrow we'll start at 8. Tomorrow.
Okay, tomorrow we will talk. What is the plan tomorrow? You are done? Any questions?
Thank you.
All of you?
بس دكتور question about the specific color.
Sit down, sit down, sit down, sit down. Please sit down. No, because sound is coming, I am not able to.
About the specific color. You say that the kid will get 20.
Highest score?
The highest score is
Normal.
Not spastic. Not spastic.
Not spastic.
Spastic factor is absent.
In the morning, the first kid we saw, He got 20, and you categorized him as a hypotonic.
I presented your case.
Yeah, the last one.
No,
Yeah.
trisomy 21 morning, trisomy 21. So come about the case.
Down syndrome.
Oh,
Yeah,
okay,
Down
21.
syndrome one.
Yes, yes.
It is 20.
Correct.
Yeah, and she is hypotonic.
Correct.
And this patient is 22,
Okay.
and there is no tone.
Not 22.
Not 22.
20, sorry, 20.
No, wait, 22. Yes. Huh? Correct.
So,
So how to say?
yeah,
So which one is giving you hypertonic presentation? That is the scarf sign. Sorry, French angle.
sorry.
From French angle, you are getting. Child is having excessive mobility.
Okay. So
He is
we
not
don't,
spastic?
Judge
Spastic
just from
component
one
in the
column.
baby is absent. In this baby, what we presented, there also spastic component is absent. So because spastic component is absent, so we are not seeing any other problem except crawling, except standing. Child is 13 months old, 15 months old, 15 months, right? 15 months old baby.
But we cannot judge from just from one column is the baby is spastic or
No,
not.
from the column, you can say that whether vestibular factor as a factor is influencing the development of the baby.
More than the other.
You can say that. Whether head and trunk posture is influencing the development of the baby. You can say that. Whether spastic component is influencing the development of the baby. You can say that. When you do the factor analysis, which factor is causing low score for the baby, that you can justify. Okay? But as a whole, if you say that how I justify child is hypotonic, okay?
Yeah.
You are looking at the presentation. Can the spastic component be able to use to justify the hypertonicity? No. Because child is not hypertonic, that's why spastic component is giving you full score. Had the child been spastic component would have given you less score. So in the both cases, your child was not spastic. Clear? So now, which component is affecting? So you have a French angle that is affecting the baby. Okay? Then you have that is this one, that is what is called posture. Lower extremity. Yeah, lower extremity. It is the lower extremity that is affecting you because lower extremity child is getting 12. So what you saw in lower extremity, too much of abduction, amphibian posture. Papa spoke to you about amphibian posture. So much of amphibian posture. That is what is affecting. Okay, that is another area. Okay.
That's why you're saying about the special bands.
Yeah. Okay. So how you look at your body? Look at the beauty of body is hip joint and shoulder joint both are in one line. Look at anatomically, it falls in one line. Okay. Have you ever thought of in your dream that somebody will get adductor contraction? Adductor contraction, have you ever thought? You always are prefixed that child will have hip abductor contraction. You are prefixed that child will have hip adductor contraction, right?
Yes.
You are not even mentally agreeing that child will have hip abductor contraction. These children who doesn't have hip adductor tone, their hip abductor is overactive. And that is the reason they take the hip in abduction. Further, what limits the excessive range of motion? The ligaments. Ligaments is a genetic makeup. If your parents are hypermobile, your ligament will be hypermobile. If you are any syndrome, your ligament will be hypermobile. Ligament gives you joint stability. If your ligament is hypermobile, it will move your joint far away. Now with this position, do you think child will walk? If I am in this position, do you think I will ever be able to walk? No way possible. This baby I showed you walking with abductor gait. But still one side there is equinus. That is called postural strategy mechanism by the baby. And so equinus. Laxity is bringing the equinovalgum. Okay? Subject to clinical judgment, clinical examination, what we see. So the Down syndrome baby, what you see is joint is unstable. When the joint is unstable, the outer muscles, lateral muscles will become active. So to make these lateral muscles inactive and make the medial muscles active, we put the pant. So the story of this trouser is like this. Now is that clear? So when the pant will be put together, the hip joint will come in line with the shoulder. Abductor will be inhibited, adductor will be facilitated. Shall we get corrected?
Excellent.
So the story, how we came with modified trouser, I just tell you because you are asking, because mainly because you will not get in literature, okay? So one day I was sitting with the baby, okay? And in my clinic I always wear this kind of a flexible cloth, okay? So as I was sitting with the baby, then I stood up, okay? Then what happened while standing, my this foot got stuck here. And then I was not able to stand. That time I had a baby who had this problem. So then it got clicked that if my leg can get stuck, why not stitch the trouser in the center? We stitch the trouser in the center and we solve the problem.
Modified trouser.
So we have given
Good
name
idea.
modified trouser. We thought of projecting it as a research, but data is in the computer, not getting time. No excuse.
Thank you. We'll start 8 a.m. إن شاء الله tomorrow. 8.
Okay, I just tell you. Yes.
Yeah.
Sorry. Yeah, degree of abnormality for which baby?
For any baby.
Yes.
How do I choose if it's not based on the specific?
Transient is there, you will not choose. Transient is there, you will not choose.
Yeah.
Only if the abnormality is there, you will choose. So in his case, we will choose as a hypotonia. You have to take as a gross judgment.
Gross
Okay? Gross judgment you have to take.
picture of the baby.
You will judge it as hypotonia. Hypotonia due to what? Down syndrome. You will have another hypotonia. How much time you have? That you have to tell me. Because more you are asking me question, more I have to dig my past. Okay, let me see.
يا عم مش بتاعتي. يا عم
بتاعت أنا. طيب ما تروح تفضل كده خلاص.
يلا نمشي. يلا ايه. خلاص خلاص.
خلاص دي واحدة كده فوق.
ما ينفعش تاخذ كذلك والله فاتك الشارع كمان شغله مقطع تمسح وخل من فوق